right. Hi, everyone. Good morning. Happy Saturday. Thanks for spending time to have this conversation. My name is Natalie Bowers. I am the current president of the North Shore NAACP branch, and just want to welcome back to this forum Dr. Stern and her team from AdMeTech Foundation to talk again about prostate cancer and get some COVID updates as well. I think we have a wonderful group of people to have this conversation today. I would like to introduce Senator Joan Lovely, Representative Daniel Cahill. They have been long-term champions of the prostate cancer educational program for high-risk men, with the priority focus on African-American and Hispanic individuals. And then we also have Dr. Zapala, who is dialing in from Hawaii right now. So it's 3:20 in the morning, but there may be other doctors joining us and things, because I think there was a big conference for the urologists. Thank you for being here, Dr. Zapala. Would love to just go ahead and pass it on to Senator Lovely for some remarks. Thank you.
Thank you, Natalie, and good morning, everyone. I want to thank the North Shore NAACP and the AdMeTech Foundation for inviting me to join you and offer some brief remarks this morning. I've had the pleasure of working with AdMeTech and Dr. Faina Stern for the past several years. Dr. Stern is a powerful advocate for AdMeTech and the work they do to ensure our communities of color are getting the screening they need to diagnose and treat prostate cancer. Racial inequities in our healthcare systems are nothing new. They have been prevalent for many years in prostate cancer, in maternal health, in overall indicators of health. And the COVID-19 pandemic has cast these inequities into the spotlight and has exacerbated them substantially. The pandemic itself has been an illustration of how communities of color often bear the brunt of these health crises. Black Massachusetts residents had COVID at nearly double the rate of white residents. And for Hispanic and Latinx residents, the rate was 3 times higher. These numbers are truly staggering. But for those who follow racial inequities in our healthcare system, this did not come as a surprise. These inequities are reflected in persistent health disparities and increased prevalence of disease among communities of color. Now that we have measured these inequities during COVID, we can absolutely enact positive change. The greater the focus on diversity, equity, and inclusion in the workplace, especially in the healthcare sector, will lead to a more culturally competent workforce and one that is more reflective of the communities they serve. We see this in our classrooms as well, and trying to make positive change there as well. Furthermore, as we work to address these inequities, we must ensure the voices of those who have lived experience. It will take collaboration and partnership in order to move forward toward a more equitable system for all. I know this conversation is a step in that direction, and I'm grateful again to both the North Shore NAACP and AdMeTech for their hard work and dedication to help eliminate racial inequities in health. Thank you again for the opportunity to join you for this event, especially with my friend and colleague, State Representative Dan Cahill, who happens to be the funniest person on the planet. And I'd like to turn it over to State Rep Cahill. Thank you very much.
Thank you, Joan. Thanks for the introduction, Senator. I couldn't have asked for a better partner in the Senate to work with. Please don't tell my Senator Brendan Crichton that. He'd be very jealous of our relationship. But I am also very honored to be here today in support of prostate awareness and working in partnership with AdMeTech, who have been a tremendous force on Beacon Hill, as Senator Lovely had pointed out, and our opportunity to discuss this and raise awareness with the North Shore NAACP. As Senator pointed out, prostate cancer is something that's prevalent in our community and something that's often avoidable for many men. However, early screening is vital. And by the way, I have zero background in healthcare, especially with prostate, but Dr. Stern spends a ton of time with every single legislator to educate us, to make us sound like we are working in the field. So this is basically regurgitating what Dr. Stern tells me on a quite frequent basis, but we're grateful for it because it's raised tremendous awareness. And I think you've seen increased funding for the types of programs that Dr. Stern has advocated for over the course of the last decade. And the investment that both the House and the Senate has made in increasing that funding has led to really, I think, great breakthroughs in early screening of prostate cancer. When we're talking about communities of color, it's also men in general. They're terrible patients. I can tell you that because I am one. The fear of going to the physician, the fear of finding out that what could be wrong with you, and the very evasive procedures that used to exist for prostate screening, and now through the good work of Dr. Stern and her partners in healthcare, those screenings are becoming much less evasive, and men should take advantage of these types of procedures. You can't make it much easier for us, so now it's just a matter of making those appointments. But with communities of color, it's even more dire. We need to reach out to those communities. We need to make sure that Latino men, Black men, and Asian men as well understand that they need to get screened early, that if they let it go too far before they get the treatment they need, it's just not, it's a much more difficult road for them to haul. And it's an increased cost of healthcare. So preventative medicine is always going to be the best road for us to take, especially as healthcare costs continue to rise, and needless delays in screening where we have the technology today to be able to do it. It's all about awareness. And I'm really, really proud to be a partner with Senator Lovely and AdMeTech and all our partners to make sure that the folks who need to know about these procedures get the information, and also, most importantly, get access to treatment. Dr. Stern's worked with many of our partners in the community health centers and other types of healthcare providers, really to dig down deep. So I'm honored to be a supporter of AdMeTech and the funding that we have for prostate awareness, and to work with Senator Lovely as well as we kick this prostate cancer's problem in the ass. That was for you, Joan.
Would somebody edit that? Thank you, Representative, and thank you, Senator, for your comments. I'd also just like to pass this on to Dr. Zappala for his wonderful presentation.
All right, I'll pop it up now. First, I want to thank everyone for inviting me in, and Matt Cooperberg, Senator and Representative, you're spot on. There are inequalities, and I think one of the greatest things is fear of men going to the physician. What will they do? Is it going to be invasive? And quite honestly, in the past, if you were diagnosed with prostate cancer, the treatment options were so horrific that men didn't even want to be diagnosed. But what I'm going to try to do this morning is give an overview on early detection, and the fact that with early detection and earlier diagnosis, it can actually be quite a minimally invasive technique to cure people from prostate cancer. And one of the greatest things, I can give an overview, but I think it's very important, it's critical that physicians meet with their patients face-to-face now. We're getting beyond the Zoom phase. We can do Zoom calls, and you can ask as a patient, doctor, what do you think? Am I at high risk? What should be the next step? And remember something, although we'll talk about prostate cancer this morning, there are other things that have to be evaluated in that same population: diabetes, stroke, and coronary disease. And most men come in and they ask me, doctor, what's my risk factor? And I say that it's really not a risk factor for prostate cancer, but indeed, there are risk factors. We look carefully at the family history. We look at environmental concerns such as diet, some chemicals, and even the hormonal imbalance. And clearly we recognize that prostate cancer is much more prevalent in older men. But the number one risk factor, I believe, is race. And the African-American subset is so critical for us to reach out to and screen. And I'm going to post this QR code. And if you go onto the American Urologic Association's website, there are so much literature and so many things for patients and also for primary care physicians to access data. And I've used this for all of our handouts in the office, and patients recognize, wow, this is becoming an issue. And there's clearly a pathway they can follow. Prostate cancer, as you know, was on the minds of all men over the age of 50. They all come in talking about it. But I think what's more important, it's on the minds of women. How many moms come in with their sons? It's unbelievable. And I think women are driving men into the office more often than we think, because they're concerned. The men think they're Goliath and nothing's going to happen to me because I'm the master of the home. And then they get struck with a diagnosis like prostate cancer, and they ask, Why didn't we find this earlier? And I think that's what we're going to try to focus on this morning. Clearly, early detection. If we capture the cancer early, we know which population to screen because they're at higher risk. We can do that. So we need selective screening. And screening routinely involves two major areas. One is a simple blood test called a prostate-specific antigen, which is a blood test and the results are back routinely within 24 to 48 hours. And we'll monitor the absolute value, the velocity of change. We'll also look at other parameters with that. And we combine that with a digital rectal examination. I'll tell you a funny story. In Andover, we have a lot of engineers between Raytheon and Lucent and Nokia and Hewlett Packard, and they come in always looking for a digital rectal examination, as if it's some probe that we place inside their body. But it's actually the human digit, our finger, and we'll feel the surface contour of the prostate. And it should have a rubbery texture and be smooth, soft, and doughy. What we don't want to feel is a prostate nodule, which would be like palpating a hazelnut on the surface of that marshmallow. So when the total PSA comes back suspicious, either the primary care doctor or the urologist may do something different. I think the years of PSA as a standalone independent biomarker are now done. We use novel biomarkers, whether they're urinary or blood-based. I routinely use the 4K score test, which provides risk. When you can run 4 different types of PSA, combining with clinical data, we assign risk to an imperfect assay, such as the PSA. And secondarily, I like to use the multi-parametric MRI, which is, again, it's non-invasive. You go for an MRI of the prostate, and these results are routinely back in our office within 48 to 72 hours. But to be frank and honest, in that high-risk population, I'll do both. I'll get biomarker panels to ascertain what is the risk of this man having high-grade cancer. And that tells me who should have a biopsy. And secondarily, the MRI tells me where should we focus the biopsy. We call that targeted lesions, and we target the biopsies. A prostate biopsy is a somewhat minimally invasive procedure. It can be performed transrectal or transperineal. We routinely use antibiotics to minimize the risk of infection, although 4% of people will develop a rather significant infection. It can either be done in the office or in an ambulatory center with some mild anesthesia. We do obtain tissue, routinely 12 to 14 cores, and we study these under the microscope. It's routinely called the histology, and then we can ask for further testing. If an area of the prostate on the core looks suspicious but not enough to say is it aggressive, we'll do some gene testing on that. And one of the newest tests that we're performing in all patients who are diagnosed with prostate cancer is called a PSMA PET CT scan. And it's a prostate-specific membrane antigen CT scan. So it tells us, is there any biological activity directly reflecting prostate tissue in the pelvis in the region of the prostate? And we're using more and more of this, and your physicians will talk about that as well. But clearly, we'll keep going back to early detection. We need to get more screening, because when we detect the cancer early, it's organ confined. When it's organ confined, you have all these options for total cure. I like telling a cute story. Every time I see a man who comes in with early detection, I said, I have good news and I have bad news. I said, the good news is we caught your prostate cancer very early and we have multiple treatment options. Oh, the gentleman will say, well, what's the bad news? The bad news is we caught your prostate cancer early and we have several treatment options. Indeed, people are becoming confused because there's so many treatment options. But I make it analogous to a gentleman who goes to play golf and they have all these clubs. And which club does he choose? Well, he looks at the terrain, the distance. So these are the factors that we do. So what factors do we employ before we make a decision on what's the best option for cure? We look at the tumor grade. We have a Gleason score, not related, by the way, to Jackie Gleason. And we have a staging that we say, is it confined? Does it extend to one side or both sides? And what's the integrity of the capsule of the prostate, that cellophane wrapper? We look at the patient's age and comorbidities. And by the way, it's so important not just to look at someone's chronologic age, if he's 61, but their physiologic age. You may have a 72-year-old who's playing golf 3 days a week and taking care of his 92-year-old father. And expectations. What do patients expect? Some don't want total cure. Some say, I'd rather choose the active surveillance route. And some say, I can't envision myself being cut open. I'd rather choose another technique. So patients' expectations must be adhered to, not just the physicians. So what options do we have? And truly, it depends upon the grade of the tumor, like I stated earlier. Active surveillance is now becoming critical. It's no longer called observation, which is what I used to call intentional neglect, but active surveillance is we'll see these patients back routinely every 4 to 6 months with a repeat PSA, follow-up biopsies at 6 months. and then repeating the MRI as well. But if we see any change in the activity with PSA, any increase in the indicators on the MR, we'll actually suggest those men leave active surveillance and go on to one of the other approaches. Surgery has historically only been conventional with the small midline incision from the belly button down to the pubic bone with 2 nights of hospitalization. But nowadays, it's almost rare to see an open procedure. These are mostly, I estimate 90%, being performed robotic with 5 small holes placed through trocars into the abdomen. Yes, there are risks and there are complications to everything we do in life, but specific to a prostatectomy are the inability to perform achieve an erection sufficient for vaginal penetration without the assistance of any of the oral agents, and also the involuntary loss of urinary control. Radiation has 2 types. It can either be external radiotherapy or brachytherapy. And I just want to show you what it looks like in robotic surgery. Too many patients believe that robotic surgery is like Detroit, Michigan, when they're building a car. No. The urologist sits at a console, and when his head goes inside this box, he shatters a laser beam, and it activates the controls. So it's tactile robotic surgery. Here the patient is lying down. There's 5 robotic arms that are doing the work, and these are all completely mobile, and they work extremely well. But the horizon's expanding. We're now looking at focal therapy versus total removal of the prostate, which we call a radical prostatectomy. And these focal therapies require attention. HIFU is high intensity focused ultrasound. TULSA is also an ultrasound delivered transurethral. And now we have interstitial or focal laser therapy that can be done in the office. Find the tumor when it's small enough and it's isolated, place a laser directly inside, and actually ablate all that tissue. And this is receiving incredible attention. I think this is going to be the future. HIFU and TULSA require anesthesia, but again, dramatic results. I'm here at the conference. We had 2 days dedicated to minimally invasive techniques, and I believe this is going to be the future. But once again, go back to that first slide, early detection and proper screening. And finally, I want to talk about what happens if it's advanced disease. And we use ADT, which refers to androgen deprivation therapy, because prostate cancer is so dependent upon testosterone. So if we can wipe out testosterone, we can lower down the progression of the prostate cancer. Thereafter, we have to use chemotherapy. But nowadays, we're also looking at new things, that is radiotherapy with targets. So we're using new isotopes, combining the PET scan with some powerful isotopes. So we're making great progress, but clearly more needs to be done. We as surgeons must work carefully with teams such as AdMeTech, which is getting the word out there. And obviously, it's our political colleagues, both in Boston and in Washington. The future is bright, and the horizon is in grasp of our hands. But we need all of us to work together. We're not competitive. We're going to be working in a complementary manner. Thank you very, very much. Oh, there it is. So spread the hope, basically. Thanks so much. I'll be glad to answer any questions if there are.
Yeah, thank you so much for taking us through that. These advances are very impressive. And one of the questions that I have is, within the urology practice, I mean, there's awareness that AdMeTech is really championing, right?
Correct.
What are the urologists doing to sort of ensure that any potential implicit bias in their service doesn't bleed into their dealings with patients of color internally to the concentration? Can you speak a little bit to that too? Because, you know, North Shore is a majority white demographic. Can they feel ensured that the urologists and doctors at large really are aware of these disparities?
Yeah, I think those are great questions. And I think first and foremost, don't look further than the woman sitting next to you, which is Faye Stern. I think AdMeTech has done a phenomenal job of getting the word out there. Secondarily, we can take physicians like myself, and we volunteer time at the Greater Lawrence Family Health Center. One afternoon a month, we teach all the residents from Greater Lawrence Family Health Center come to our practice and spend at least 3 or 4 days a month learning. And it's astonishing when we educate them, and these are the family practitioners who are going to be going out into the ranks to say, listen, we really have to focus on this Hispanic population. So we need to get the word not just to the surgeons, because we as urologists understand that there's racial disparities, and it has to go to the primary care doctors because they're seeing the patients in the forefront. It's astonishing that the trail doesn't begin with me, it ends with me, but way back there, early detection is on the other side of the curve. Medical students, family practitioners, and primary care providers who are getting slammed, by the way. It's very difficult for them as it is.
Yeah.
And I would
and
take it,
Phil,
and I would take it further, and I would say, beyond medical community, we need to let men and their families know. And that's the purpose of our program, to empower men to know what questions to ask of their physicians, and to make sure that if his physician is not ordering, let's say, PSA screening after the age of 40, to start a discussion, to initiate discussion of the physician. Why can we discuss prostate cancer screening? Can we discuss PSA screening?
Yeah. And Dr. Stern, as the director of AdMeTech Foundation doing this work, would you like to, should we open it for public discussion, and would you field those questions?
Actually, if you do not mind, Natalie, I would like to go ahead with my presentation.
Oh,
because
sorry.
it will focus on a number of advances. But the primary focus of this presentation is to describe our new program, Prostate Cancer Equity Program. Traditionally, up until last year, we had educational programs for medical community, for general public, like we are having today. Over the last year, we launched a new program, which is called Prostate Cancer Equity Program, which directly gives everyone in Massachusetts who is interested, who is 40 and older, access to outstanding prostate cancer experts, such as Dr. Steven Zappala. And I will describe this program, how it works, and how we are passionate about bringing the cutting-edge advances in prostate cancer care to everyone. Dr. Zappala described very exciting advances in screening, diagnosis, and treatment. They popped up, actually, most of them popped up over the last 5-6 years. And it is very important to make these advances available to everyone. If we don't, we will see increasing gap all over again between patient outcomes for Caucasian men vis-a-vis Black and Hispanic men. So we actually, as a matter of course, right now, we've had so many different problems with PowerPoint presentations in our many events that, as a matter of course, we started videotaping, pre-recording my presentation. So Emma, if you will be kind enough to please start my video presentation. My name is Faina Stern. I'm a physician and founder of the AdMeTech Foundation. I'd like to express my gratitude to Natalie Bowers of the North Shore NAACP for the partnership since last year, including her invitation to take part in this event. I also would like to thank AdMeTech staff, particularly Emma Coyert, Thomas Satam, and Trisha Kinney, who made this event possible. AdMeTech Foundation provides leadership for the groundbreaking programs in prostate cancer at the state, national, and international levels. Our programs have been transforming the standard of patient care for everyone and reducing health disparities in Black men. Dr. Steven Zappala reviewed the recent and exciting advances in screening, diagnosis, and treatment of prostate cancer. I'll focus on our new Prostate Cancer Equity Program, launched recently to bring these advances in patient care to every man in Massachusetts and eliminate health disparities. Prostate Cancer Equity Program is an important part of the AdMeTech's ongoing statewide program in prostate cancer that created a Massachusetts model of national leadership in public awareness, medical education, and research. We are grateful to the North Shore delegation to the State House who made this program possible. Our primary focus is on high-risk men, Black, Hispanic, and Latino individuals, and all men with family history of prostate cancer and increasing age, 50 and older. This program was started in 2009 in collaboration with multiple organizations and has 3 components: public awareness or community education, medical education, and research. For public awareness and education, we had reached well over 36,000 men since January 2020. While we are dealing with COVID pandemic, prostate cancer cannot wait. And yet many men avoid visits to their doctors out of understandable concern of contracting coronavirus. Unfortunately, delays in prostate cancer care can cause reduced quality of life and even loss of life. Clinical facilities created a safe environment for patient care, including virtual visits, telehealth, ongoing in-person care, doctor's appointments and testing, and medical procedures such as biopsies and treatment. Ongoing care is particularly important for Black, including Hispanic men, who are 2.5 times more likely to die compared to white men in our country. However, early detection saves lives and eliminates health disparities. With early detection of prostate cancer, every man is alive in 5 years. In sharp contrast, with late diagnosis, when cancer is spread to other organs, only about 28% of men remain alive during the same time. In prostate cancer, screening with blood tests called PSA is the best tool we have for prevention and early detection, critical for saving lives and reducing health disparities. During pandemic, it is more important than ever to take charge of your prostate health. It is important to know your risk factors, such as Black heritage, family history of prostate cancer, particularly in a brother or father, and increasing age, 50 and older. You can ensure early detection. During annual visit, ask your doctor about PSA blood test and digital rectal exam. You need to talk to your doctor starting at the age of 40 if you have risk factors, or at the age of 45 if you do not have risk factors I just mentioned. Before screening, it is important to avoid exercise or sex, which may impact your testing results for 1 week. After screening, you need to ask your doctor if your test is normal or if you need to see a prostate cancer expert for further evaluation. The centerpiece of our medical education is AdMeTech's annual Global Summit on Precision Diagnosis and Treatment of Prostate Cancer. The latest 6th annual conference took place this year between September 22nd and 24th. Our summit brings together the key international experts representing every clinical expertise to review the best emerging clinical practices. This educational event showed rapid advances in patient care. In screening, our summit supports clinical guidelines for early detection recommended by the National Comprehensive Cancer Network, consisting of over 28 cancer hospitals and their leading experts. As mentioned, high-risk men, including men with a Black heritage or family history of prostate cancer, are recommended to start screening at the age of 40. Average risk men should start PSA screening at the age of 45. This first or baseline PSA result in younger men has emerged as one of the most important indicators for developing lethal prostate cancer long-term, over 10 years. In diagnostics, we have seen emergence of very accurate non-invasive tools such as blood, urine, and saliva analysis for molecular and genetic markers, and advanced imaging, including ultrasound, MRI, and molecular imaging. This non-invasive diagnostics, highlighting the importance of PSA screening, shifted past concerns about screening for prostate cancer into a dustbin of history. For example, these diagnostics can determine which individual man has an increased risk of life-threatening, rapidly progressing prostate cancer, improve early detection, critical for saving lives, reduce unnecessary procedures such as biopsy and treatment, and optimize selection of personalized care for each man, including careful observation or active surveillance, minimally invasive interventions, or immediate radical treatment. High-risk individuals, including Black men,
carry higher risk of both mortality, dying of prostate cancer, and unnecessary procedures. Consequently, it is critical for them to have access to precision diagnostics that determine for each individual man if he should or should not have invasive biopsy or treatment, and what options in clinical care are best for him. Unfortunately, in Massachusetts, Black men are less likely to have precision diagnostics, such as advanced imaging, MRI, or molecular imaging, or genetic testing, or undergo life-saving treatment compared to white men. Prior to undergoing invasive biopsy or treatment, it is important for each man to discuss with his doctor if any testing is available to determine if these procedures are actually needed, and if yes, what kind of options would work best for him. For example, in this slide, magnetic resonance imaging, or MRI, shows prostate cancer lesions and guides biopsy needles with precision. AdMeTech has led research development and large-scale clinical implementation of prostate MRI since 1998. Our summit highlighted the importance of MRI in Black men, who are more likely to have lesions in the front part of the prostate that are difficult to find by physical exam or standard blind biopsies performed without accurate imaging. In men with prostate cancer, there are two pillars of the current diagnostics: MRI and genetics. While MRI shows cancer location and local spread or stage, genetic analysis of cancer tissue reveals underlying biology and probability of progression. Emerging data indicate the importance of genetic testing for many high-risk men, Black men in particular, for selecting the most effective treatment. With this precision diagnostics, we can now accurately determine if each individual man has a slow-growing, what we call harmless prostate cancer, or needs a careful observation, or an aggressive version of prostate cancer requiring immediate life-saving treatment. More recently, molecular imaging has been shown to play an important role in staging of prostate cancer, including presence of metastatic spread and detecting return of prostate cancer after treatment. For example, PSMA molecular imaging has been approved by FDA within the last year and become available at the Dana-Farber Cancer Institute since August 2021. On the left, right here, we can see a traditional bone scale showing no metastatic spread. However, on the right, in the same patient, molecular imaging demonstrates extensive metastasis. This information is important for selecting appropriate and effective treatment. We are proud to have led research and development of molecular imaging since 2001. Based on the evidence coming from military medicine, from veteran administration, our summit concluded that equal access to high-quality care is the key factor in improving patient outcomes for all men and eliminating health disparities in Black men. It is particularly important now with so many novel diagnostic and therapeutic approaches, ensuring high-quality personalized patient care. Without equal access to these advances in patient care, we will see a widening gap in health inequalities, including survival and mortality. Consequently, AdMeTech launched the Prostate Cancer Equity Program in Massachusetts in collaboration with Mass General Brigham, UMass, and other clinical institutions with the mission to save lives and deliver high-quality care. Supporting organizations include Latino Health Insurance Program and NAACP New England Area Conference with their multiple branches located across the state. Our goal is to expedite access to leading experts who use the most advanced approaches to screening, diagnosis, and treatment available today. This program helps men to find an expert for the initial or a second opinion, in-person or virtual visits. Any Massachusetts man age 40 and older can participate. Our priority focus is on Black, Hispanic, and Latino men who are at higher risk of prostate cancer, delayed diagnosis, poor quality care, and death. We believe that in Massachusetts, with its leading hospitals and universal access to care, our prostate cancer equity program will be able to eliminate health disparities. Experts of the prostate cancer equity program can address any questions about prostate health, from assessing an individual healthy man's personal risk of cancer to informing men about all available options before and after screening, biopsy, and treatment. We are committed to supporting men during every step of their medical journey to ensure that no man is left behind or struggling alone. To achieve this goal, we created a streamlined VIP-style process of patient referral and care, reflecting how a physician like me takes care of my family and friends. This process consists of 3 components. 1, AdMeTech Foundation's coordinator collects basic information and matches individual patients' needs with the appropriate state's experts. A clinical organization designates a patient navigator who works with multiple schedulers to expedite a medical visit. If an expert recommends any next steps, for example, additional testing or treatment, AdMeTech's coordinator and patient navigator work with men on the appropriate follow-up. To ensure successful implementation of this program, AdMeTech has created a network of leading state experts committed to eliminating health disparities, develop an effective process for patient care and follow-up, as mentioned, recruited community coordinators in high-risk areas who mobilized a network of over 100 program ambassadors, community, organization, and church leaders, held multiple focus groups to develop program materials. Our current goal is to identify and mobilize appropriate organizations and individuals so that men, their primary doctors and caregivers have access to this program. Trisha Kinney, a member of the AdMeTech Foundation staff, serves as a statewide coordinator for the Prostate Cancer Equity Program. If you have any questions or need assistance, please contact Trisha by phone, 617-523-3535, or by email, coordinator@admetechfoundation.org. Thank you for your attention.
Trisha, do you want to, Trisha Kinney, who is managing this program for AdMeTech, is here with us today. Trisha, would you like to share why you're so passionate about Prostate Cancer Equity Program?
Hi, yes, absolutely. Hi, everyone. I'm the coordinator of the Prostate Cancer Equity Program. So if you were to contact AdMeTech via email or call, I would be your first contact person. So the reason I value the Prostate Cancer Equity Program so much is because it acknowledges that finding healthcare, especially in terms of prostate cancer and navigating insurance, can be a strenuous process. And our goal at AdMeTech is to make sure that this process is as easy as possible for patients. Another reason is that we really encourage screening, which is essential in order to prevent prostate cancer. So I encourage you and welcome you to join our program to get screened, even if you do not have symptoms of prostate cancer. A really strong emphasis of this program is that quality healthcare is available, especially in the state of Massachusetts. And we want to affirm that this quality of healthcare needs to be accessible to all in order to end health disparities. So this program is an important step to seeing mortality rates of prostate cancer reduce in Black men. So if you have questions, feel free to contact the email coordinator@admetechfoundation.org. And then our website is admetech.org, so you can read more about our program there. There's much more details about our program there, and I'll put it in the chat as well. Thank you.
Thank you so much, Trisha. Once again, if we were to issue one call of action as the result of this educational event. If you need help, if you have any questions at all, if you're a healthy man and have questions whether or not to get screening, when to talk to your physicians, if you recently were advised biopsy and you're wondering if you actually need biopsy or need further diagnostics, if you had biopsy and were diagnosed with prostate cancer and are concerned about what kind of therapeutic options, therapeutic interventions will be appropriate for you, and what kind of minimal interventions, minimal treatment can be available to you, please contact Tricia. If you had treatment and you develop complications, we will help you connected with the best physicians in Massachusetts in order to get either a primary care or a primary care for prostate cancer prevention, diagnosis, treatment, or a second opinion. We just were joined by one of the world leading physicians, world leading experts in prostate cancer. We are really lucky that Matt Cooperberg, who is truly leads the world in research and clinical care, similar to Dr. Zappala. He actually agreed. Dr. Zappala invited him to join us, and he is today with us from San Francisco. Dr. Cooperberg has been leading every major research study, every major clinical trial over the last 10, 20 years that is changing clinical practice across the globe. Matt?
Good morning. Good to be here.
What is the time in San Francisco right now, Matt?
7:15.
Thank you so much for joining us.
It's a pleasure to be
Now,
here.
we had a brief overview about prostate cancer in the underserved, and especially in the African-American subset. Matt, you've done a tremendous amount of work looking at the underlying gene mutations. Should we be looking at more genetics in this subgroup of African-American men? And are there any other tests like genomic profiles when we establish the cancer in these men? Could you address both of those questions?
Yeah, fantastic questions. And they're both questions of a huge amount of ongoing research. You know, the best studies suggest pretty clearly that Black men get obviously more cancer, worse prostate cancer, and that it starts earlier. You know, interestingly enough, studies that have really looked at outcomes among men who have the diagnosis suggest that the trajectory, you know, the growth of the cancers are actually fairly similar between white men and Black men, but that it starts about 5 years earlier among Black men for reasons that are still not fully understood. It is almost certainly some combination of genetics and environmental factors. And when we say environment, that's everything that is not genetics. So that is diet, smoking, stress, and then there's the question of access to care. On that latter point, the last point, we may actually be making a little bit of progress because we know that by far the most important thing we can do for men at risk for high-risk prostate cancer is to screen, and to screen relatively early with PSA testing. So there are an increasing chorus of voices saying that we really should be offering PSA testing to all men at a young age, but probably even younger for Black men. So at UCSF, where I work, we've worked extensively with the primary care groups to come up with a screening protocol, which we've now implemented, which starts at age 45. And there's a recommendation to even think about testing at 40 for Black men, especially if there's any prostate cancer family history of high-risk disease. And PSA itself remains an incredibly good test, especially when it is used at young ages. Now, the thing about PSA, which is prostate-specific antigen, is that as men get older, there are other things that rise the can drive up the PSA. But for younger men in their 40s and early 50s, PSA really indicates risk of prostate cancer. And the numbers are actually very similar. The medians, you know, where the PSA should be between white men and Black men should be under 1, at least up until age 60. And if it is, which it usually is, that's very reassuring. But when it's higher, this is when we need to think about additional testing with things like, you know, there's blood and urine tests that we use quite extensively. There's MRI to figure out who needs a biopsy. Your second question about are there other tests in terms of genomics and all that, that's a little bit more controversial. Some studies have suggested different genomic patterns between white and black men diagnosed with the cancer. A lot of other studies have not found these. It probably doesn't matter all that much. It's a relatively small contribution relative to the major contribution we can do in just finding the cancers when they are still curable and treating the ones that need to be treated. That's the other point, is not over-treating the low-risk ones when we find them.
Great comments. Wow. Faye, I turn it back to you.
Matt, if you were to formulate a home take message for black men or any high-risk men, men with family history, for example, even if they're white, particularly in brother and father, what would be the take-home message?
The one-liner, the two-word answer is get screened. We've been through lots of controversy over the last 15 years about the value of PSA screening. We have the U.S. Preventative Services Task Force, which is the national guideline panel, which makes recommendations about screening, who have really gone back and forth. They've tended to be very opposed to screening in the last decade. They're now thawing in this regard. And I think primary care docs are kind of waking up to the value of this. We know how to use PSA well. We hadn't always used it well as a community of both primary care docs and urologists. But when PSA is tested early, it is an incredibly reliable, valuable test. About 75% of men that get a PSA check will have a low value and can basically stop worrying about this. But men who have high PSA at baseline, these are the men who are at risk of actually dying of it years down the road. The other thing to know about lethal prostate cancer among black men is that the biggest excess burden, meaning the biggest gap between white and black men in terms of actually dying of prostate cancer, is seen for younger men. So the black men who are at most excess risk of dying of it are those of younger age, which is one of the reasons we recommend early testing. So if your primary care doc is not raising the question about PSA testing, you should be asking for it. Now, again, the key caveat there is that what we are looking for when we screen for prostate cancer is high-risk disease. Prostate cancer is a huge spectrum. If you live long enough, almost every man is going to get a couple of cancer cells in the prostate, and most of these don't matter. The ones that we call low grade, based on how they look under the microscope, we do not need to treat. We follow these. But the ones that are aggressive, these are the ones that we can find early, and we can cure them before they become lethal.
Thank you so much, Matt. Do we have any questions for our physicians?
We do have Kenan on the call, and she has her hand raised. I don't know if she's having audio challenges, but she did.
Absolutely. Kenan, do you mind getting yourself off mute?
Sorry, I couldn't hear anything, so I had to log back into the call, but I'm fine now. So thank you for the presentation. I would have loved for more people to be here. I think it's a little lost on a beautiful Saturday morning.
And
I guess my point is more people need to hear the message and as many as possible. I have questions swirling in my mind, but I'm going to try to stay organized. So my grandfather passed away from prostate cancer. I'm originally from Guyana. My uncle is currently, battling that as he spent most of his life in the Caribbean, and just other family members I'm aware of have this struggle. So a couple of things come to mind. Wondering about access to healthcare, who ration their healthcare decisions as well because of the type of coverage and access they have. So I'm not sure, if I didn't hear that part, where we can address the issue of free, low-cost screenings and access in the community when those opportunities for screenings and treatments are available. Medical advances that are promoted and messaged from people who do not look like them.
Okay, these are great questions. To address first question, how we can help, men in a more equitable fashion. And basically our call to action today to everyone who is listening to this program, everyone who will be listening to the video of this program, is please come to AdMeTech Foundation. We will connect you to the best physicians, best experts in the state with the best possible, most advanced approaches to finding and treating, preventing, finding and treating prostate cancer available in medicine today. And it is not an accident that today we are very aware that Black men or Hispanic men, for that matter, don't have a lot of confidence, let alone trust in medical establishment. We are working for with Latino health insurance program, and our community coordinators are members of the African community. We are unfortunately in Massachusetts, there is only one Black physician who is prostate cancer expert at the academic institution at the faculty level. Dr. Ike Madeke, I apologize, Black fully trained urologist, but he's a fellow at Harvard Medical School getting trained in urologic oncology, has been tremendous. He's been tremendous participant in this program. So relying on physicians of color, relying on trusted community leaders and organizations who supported community for decades, okay? Trusted on, leaning on trusted community leaders and leaning on physicians of color is very important to us.
Yeah, I appreciate that.
For example, a few years ago, we had an event with large Hispanic church, and this event was led by Dr. Adam Feldman and me. But Dr. Feldman brought 3 of his Hispanic urologists.
Right.
But this is changing. This is changing.
Yeah, I have a colleague who is a Black woman urologist in Massachusetts. I think just in terms of being expansive, it's really great that there is support, for example, for African immigrants, but there are a lot of people with knowledge in the community who do not have the American credentials, but were nurses in their countries and other types of professions.
Yeah.
The final thing I would say about that is generally, I think, even if we expand who gets to be in front of people, it's helpful. So it may not be physicians, it could be nurses and people who can use language that's a little more translational. That might even be helpful, I think. Other things like that have been, sort of used in ways that are scary. Also, I think make it a little more receptive.
Absolutely. And that's where the role of community coordinators, community leaders, patient navigators is absolutely critical. And these are both on the grounds. These are people who we support to be our essentially program liaisons.
Oh, that sounds great. Thank you.
And Keenan, I have a question for the entire group, including our political colleagues. And as Keenan brought up, we have to work with our primary care physicians as well as our urologists on education.
Yeah.
But one of the things I've learned with industry, what about direct to consumer? We can watch a television and my goodness, there's an ad for Pfizer, for Merck, talking about drugs that we've never heard of. Why don't they take some percentage of those funds and use it direct to consumer to address a American killer, which is prostate cancer in these underserved people?
It's I need to think a little bit more about it. I doubt it very much that major pharma or any other major company will turn around and give up their marketing revenue for awareness programs. But that's why we need to rely on the state, and we are very grateful to political leaders like Senator Lovely and Representative Cahill to have the program we are having right now. But this is just a small component of what we do, because we have prostate cancer equity program to bring high quality care to underserved men, particularly minority men. And we have a wide network of community partners across the state. So I'm very grateful to, unfortunately, when we started looking to sources of funding, when we started designing this program and we started looking for sources of funding, we realized that the best we could do is to educate politicians and get their support. And thank God, political leaders in Massachusetts, due to consistent education since 2009, made prostate cancer as their priority consistently over the last 8 years. Senator Lawley, would you like to comment on that?
Thank you, Dr. Stern. Yes, and Dr. Stern, I want to say thank you to you for coming into the State House, for educating us as, you know, we're not, most of us do not have a medical background. And it's very important to hear from our advocates on how important this is. And so I want to say thank you to you and AdMeTech for really educating us as policymakers on the importance of this, and then how do we properly assist, you know, with budgetary needs to be able to get the word out and have this be a priority for us, you know, for our policymaking and budget here in Massachusetts. So today's presentation in particular has been very, very educational. I'm a facts and figures person, so I like to take the deep dive into the medical, especially the medical process, because I don't know it. So I really appreciate that. And, you know, so I have a husband and a son, and, you know, and a son-in-law who I care deeply about and want to make sure that their needs are being attended to as well. But we consistently, and this is why we're here today, seeing our communities of color, our men in our communities of color. And as Dr. Mackenzie DeFranza said, you know, it's about equity and access. And I've heard that from all of you today. So thank you. Please know that we are here to be supporters in any way we can to get this message out and make it that this medical care is equitable. So thank you.
Thank you so much. And we approach this, I will ask also Representative Cahill to comment in a few minutes, because he made it literally after the first meeting with Senator Lovely, after the first meeting with Representative Cahill, they made it their priority. And it's important for me to to point out that we approached this from the beginning since 2009 as an issue of human rights, as an issue of social justice, because there is absolutely no explanation why, not a strong explanation, if you will, why Black men are dying at a rate of more than twice compared to white men, while early detection essentially equalizes patient outcomes. Early detection saves life for everyone. So, and that's what we also struggling with different sources of funding. We came to legislators in Massachusetts because nobody else would provide funding that we needed for research, collecting data, developing technologies that are important for everyone, and diagnostics, therapeutics, and then making it a legislative priority in the state. Daniel, do you want to comment why you became so keen on supporting our program literally from the first time we met?
Well, I think we've all kind of come to the conclusion that this is a real healthcare crisis, especially for our communities of color. So other forms, and to Dr. Zappala's point about awareness and advertising, there are other forms of cancer that have a tremendous amount of financing and funding and awareness. That comes to mind. Breast cancer is a huge industry and support for folks to combat breast cancer and leukemia. We've seen in the news a lot about lung cancer associated with people smoking and using tobacco products. Prostate cancer just never had, I think, that type of attention, but that's where advocacy comes in. It starts at the grassroots. So through AdMeTech and their advocacy at the State House, with seed money for some additional awareness, this is going to grow. And, you know, less than 49% of the population on the planet are men, or 48% or something to that effect. So it's a tremendous amount of population that's affected by it, but it's not really spoken of. It's kind of taboo, and a lot of people just don't want to deal with it. So I think this is heading in that direction. I hope it is. And as we get more public funds, it'll attract more private funds. And that's when you get that public-private partnership that'll really grow awareness, and you'll start seeing more of growth of prostate awareness months and prostate awareness PSA commercials and to that effect. So for me, it was important because as someone who represents a majority district, I know a lot of the challenges that men of color face in our society, and not just from a day-to-day basis, but also from a healthcare prognosis. And I want to make sure that my neighbors, friends, and family have the access to awareness, just like everyone else on other forms of cancer. So I'm a proud partner. I'm grateful that I got to join us today, especially with Senator Lovely and your great team and some really impressive physicians here. I think this is just the beginning of what you're doing, Dr. Stern, as far as pushing the issue and creating awareness, and it's just going to grow from here.
Thank you so much. And what I would like to point out is my career is very interesting in that regard. I was a head of diagnostic imaging, championing every major imaging program in breast cancer that is standard today. Digital mammography, telemammography, sophisticated digital analysis, computer analysis of digital imaging, MRI, advanced ultrasound, everything you can possibly imagine. When we were well on the way, I started my NCI position in 1990. By 1995, we were well on the way with all these programs, and we knew we would be able to eliminate health disparities. By now in Massachusetts, over the last 5 years, there is no difference in mortality between Black and white women in breast cancer, thanks largely to large care awareness campaign and improved care. Now, in 1995, in the middle of all of it, my father was diagnosed with prostate cancer, and I was absolutely horrified. My world was breast cancer, and all of a sudden, my father got diagnosis of prostate cancer, and I was absolutely horrified to learn there was not anything in imaging, that all of the care in prostate cancer was blind. We do not do blind care for any other organ in a patient body. And my second shock, very shortly afterwards, was the issue of disparities. When I looked at the differences in mortality between Black and white men, it was shocking to me. And I realized very quickly that prostate cancer was the leading health disparity in cancer, and probably beyond cancer. Even diabetes, hypertension, and other known disparities do not come close to the differences in mortality between white and Black men in prostate cancer. Not to mention that prostate cancer is as common as breast cancer. So we use breast cancer model for our advocacy. Breast cancer community went directly to Congress. We went directly to Massachusetts legislators to create a Massachusetts model of national leadership in research, in prostate cancer research, education, and elimination of health disparities. Steve, any take-home message from you to people who listen to this program, who will listen to this program?
Yeah, I'm going to echo what I stated at the beginning. Early detection. Don't be afraid to speak to your physician and ask. One of the comments I've always made, we call this today health care, but understand your own health, and then you'll find people who really care. I think people have to be more, once they're armed with information, they can go to their primary care physician. I'll tell my physicians or my colleagues, ask your patients, did they write down the questions? How many people come into the office, Matt, they forgot the question? And I constantly remind them, write them down, or you're gonna have to call me later. And that's very, very, because they're frightened to go. What's the PSA? They come in shaking like an aspen leaf. And I think once they understand the dilemma we have as well, we work together as a team. So I think it'll be my thing, early detection, and write things down before you go to the doctor's office.
Once again, if call to action today, is for anyone who listens, for anyone who will listen to this video, please come to AdMeTech Foundation, 617-523-3535. Please ask for Trisha Kinney. Between Trisha and me, we will make sure that you will not be left behind. You will not be struggling alone. And we will figure out what questions you need answered, and we'll get the best physicians we can to answer those questions. Natalie, back to you.
Thank you, Dr. Stern. Your passion is so obvious, and thank you for hosting this forum. Thank you to everyone that's participated. Going to close it now and just thank everyone. And Dr. Cooperberg, thanks for coming in late. I know I admire you showing up. Thanks for the work you're doing. Yeah, our branch is here to support the work. So let's continue the relationship and enjoy your Saturdays.
Thank you so much.
Thanks so much, everyone.
Thanks, everyone.
Matt and Steve, thank you so much for being here in the ungodly hour that is. Thank you for showing up.
See you soon.
Bye, peace.
Be well, everyone.